Hey, San Diegans, it's Tony Gwynn Jr., and it's Turquoise Takeover Week across the nation when the American Lung Association raises awareness to help defeat lung cancer. I'm here with my fellow board member, Dr. Tim Morris of UCSD, and with the generous support from the Sharp Grossmont Hospital, we are bringing to you a special series of community connections in San Diego, or as we like to call it, having dinners with docs. Hey, Dr. Morris. It's a great to be with you again for a Turquoise Takeover, special edition of Doc Talks. Please tell us about our this special series and introduce everyone to Dr. George Cheng, who is here with us today.
Thank you, Tony, and it's always great to work with you with the Lung Association. So as you remember, we had a number of different talks about lung cancer that really focused on that, there's still hope even if you get diagnosed with lung cancer. We talked about people, with two people about, Dr. Fuster and Dr. Moncray and Dr. Albagari about great ways to treat it and how to live with it, how to diagnose it. But today we have a real special treat, and we have Dr. George Cheng, who's really a world's expert in the use of very sophisticated instruments to diagnose cancer in a way that, or diagnose things that aren't cancer in a way that really minimizes the amount of trouble that a patient needs to go through and brings an amount of accuracy that was really never available before today. So it's a very exciting time for us to fight lung cancer. We're very fortunate to have Dr. Cheng to talk with us a little about it. So Dr. Cheng, can you tell us a little bit about what you're going to be speaking about?
Yes, thank you, Dr. Morris, and thank you, Tony and American Lung Association for having me here today. And hello, San Diegans. Today, my talk will be focused on how we approach lung nodules. You can imagine if you go to a clinic or had a CT scan that showed a specific nodule that appears on the CT scan, how much stress that may occur in your day-to-day life. And I'm here to tell you that the technology that we have today in clinic, that's in action, is able to get those nodules, give you a diagnosis in a 1 to 2 hour procedure that is safe and that is accurate. In fact, now we're actually working towards a scenario where we can perform diagnosis, staging, and treatment all in one sitting. And I'm very excited to be sharing those information with you through the talk.
Tony, things have changed in the last few years. Phones have changed, computers have changed. My beard's changed, by the way. It's gotten a little bit whiter over the years, and this has changed too. And I think it's really important for people to know that there's a very good reason to get lung cancer screening tests done now, because there are doctors like Dr. Cheng who can use that information and really help to save a life. The whole point is to get at things before they become a big problem. And this really has the potential for saving lives if people take advantage of it.
Well, it certainly sounds like there's a lot of hope in a lot of the technology. I mean, having lost a father to cancer, I know how much of a toll it takes on your body. And if we can minimize that as we're trying to fight this terrible, terrible disease, I think we all can feel pretty good about some of the new advancements that have occurred. So.
Great. Absolutely. Absolutely. I agree completely.
Well, it's a really exciting time, and as I said, it's really a time for people to take advantage of this. And there certainly are ways that you can get an early detection of lung cancer and treat it before it becomes a problem. And without any further ado, why don't we move right into Dr. Cheng's talk?
Thank you.
Hi, good afternoon. My name is Dr. Tim Morris, and welcome to the Community Connections webcast in San Diego. First of all, I would like to thank the Lung Association for arranging this and the generous support of the Sharp Grossmont Hospital. Tonight, we've got a special treat for you. We're going to be speaking with Dr. George Cheng about lung nodules and what you need to know about that. But first, before that, I'd love to welcome you on behalf of myself and my partner, Tony Gwynn. And as you may know, Tony and I have been hosting the Community Connections for about 3 years now. And if you get a chance, please do go on to the Lung Association website and see a lot of very interesting presentations that are already on there. This is a special occasion because this May 8th through 14th is the Turquoise Takeover. That's a nationwide time of celebration and promotion of the Lung Association. We like to wear turquoise, and we have various buildings and landmarks lit up. You can see, I don't know if you can recognize some of the big America's landmarks there. We'd love for you to participate and turn your social media turquoise, and to learn about lung cancer risk factors, since that's one of the things that's quite important to the Lung Association, is to reduce the suffering and death from lung cancer. Locally here in San Diego, there is a very exciting collaboration between the Lung Association and Bristol-Myers Squibb, and they're aligning their efforts to fight lung cancer here in San Diego. As one of their initiatives, they've had a very nice resource that addresses commercial tobacco use in Hispanic and Latino communities. That there's a tool kit and a webcast that have to do with this. And if you're interested in it, please use the QR code up on the top of your screen there and find out a little bit more information about it. Maybe you can register and participate in the webcast. Somewhat more relevant to today's topic is the same group is very interested in lung cancer prevention and lung cancer screening. There's a very exciting initiative regarding increasing lung cancer screening, and you can participate in that by visiting the website there. You can email, you can call toll free, or you can use the QR code up on the right-hand side to participate in that as well. Where this will take you is a very interesting web page that provides support for patients. There is a navigation team which is staffed by a nurse navigator and a resource navigator, and is focused on San Diego. And they can provide one-on-one education with you. They can help you to navigate to a place where you can have a low-dose CT scan for lung cancer screening. They can point you toward additional resources, transportation, housing, etc. And there's even a free service about tobacco cessation. If lung or healthcare providers are listening in today, you can actually refer your patients to the navigator as well. There are some support for providers as well. You can access the patient navigation through the Lung Association contact information that you see up in the right-hand side of your screen. There's free materials that you can take advantage of for your own practice. And there is a Freedom from Smoking facilitator training that is normally cost $400, but through this generous grant, we can be providing that at no cost to you at all. Now, we're taking advantage of the Turquoise Takeover here in San Diego to promote this very same initiative. So there's the LA County building lit up beautifully in turquoise. So we'd like you here in San Diego to wear turquoise to promote the association. I've just found out that it's turquoise because a clear blue sky is turquoise. Visit the landmarks, and we're going to go by to the San Diego County building and see it lit up like that sometime during the week. Turn your social media turquoise, and take this opportunity to join the fight against lung cancer in San Diego. You can learn about lung cancer risk factors, and also listen to these community connection webcasts. There are 3 total, including tonight's. 2 of them are from Drs. Montgrain and Dr. Fuster concerning the risk factors for lung cancer, the benefits of screening, etc. Today's talk is going to be a little bit more specific, and today's talk is from Dr. George Cheng, who is a UC San Diego healthcare provider in the pulmonary division, and he's an expert in the procedures that are necessary to diagnose lung cancer and to treat lung cancer. And what he's going to be talking with us about are lung nodules and a possibility of lung biopsy, and what you need to know if by some chance you are found to have a lung nodule. So with that, without further ado, I'd like to introduce Dr. Cheng, my good friend and colleague.
Thank you so much, Dr. Morris. Appreciate this wonderful introduction. And just want to verify that everyone can hear me okay.
We can hear you.
Thank you. Again, want to emphasize to everyone, I want to take a moment to thank American Lung Association for this wonderful opportunity and Sharp Grove Small Hospital for their support for what we're doing. Also reiterate that this is the Lung Force week, the Turquoise takeover week from May 8th to May 14th. Please wear turquoise and show your support. For the remainder of the time, I want to take a moment to talk about lung nodules and what you need to know. And as Dr. Morris had mentioned, I'm the director of interventional pulmonology and bronchoscopy and pleural disease at UC San Diego. My day in and day out work is to evaluate lung nodules and talk to my patients about how to biopsy and how to evaluate these lung nodules when they do arise. So I do have some disclosures. I serve consultants for a variety of companies and also receive research funding. And the topics today, we're really going to frame this as a clinical problem that is presented to you, which is the lung nodule problem, and talk about the challenges with the lung nodule management program and how we are at UC San Diego integrating blood testing in our lung nodule evaluation. And discuss about ways that we're biopsying and evaluating these lung nodules using a robotic platform known as ION. I'd like to take a moment to thank my team as UCSD, both the IP team and the PCCM group. We're a fun bunch of people. We take care of each other in order to take good care of our patients, and that kind of permeates through day-to-day work. They're wonderful. A wonderful group of individuals to work with. My nurse practitioner, Kelly Ball, and my nurse manager, Gina Maltz, deserve a lot of credit. And I also work with my partner, Dr. Russ Miller and Dr. Noral Patel. Our operations span across the spectrum of UCSD campus, both in La Jolla and in Hillcrest campus. These are the two top images you're seeing. We also function through Morris Cancer Center and the VA hospital in La Jolla region. Our programs spans across the spectrum of bronchoscopy and pleural disease. And today we're going to focus on specifically the lung nodule program. So what is the problem that we're talking about? You found out that you had a lung nodule on a CT scan, and obviously you're worried. What is the next step? What does that mean to have a lung nodule? Could it be cancer? Could it be infection? Could it be just inflammation? So this is where we're going to spend a little bit of time to consider exactly what that lung nodule could be in the worst case scenario, which is lung cancer. And let's visit a little bit about what is the state of lung cancer in 2023. Of note, there is one new diagnosis every 2.5 minutes of lung cancer. And in this past year, there's 237,000 new diagnoses, and unfortunately, 44% of them were caught in the late stage. These are the stages that often the treatment are not considered curable and involve more systemic treatment and does not involve surgical treatment. Nationally, only about 5.8% of those who are at high risk are actually undergoing screening. And if you look at which state is the worst in the screening process, you'll be surprised to find out that here in California, we are actually the worst. We're only screening about 1% of our population. And now let's take a moment to think about what happens to a patient with lung nodule and a potential lung cancer patient. Lung biopsy candidates faces a very challenging and suboptimal pathway that goes from screening to diagnosis to care. And also potentially that pathway is fraught with potential delays that often contribute to a limitation to intervention options for these patients. So when you look at all comers, on average, a patient with a lung nodule require 1.7 biopsies, so over one biopsies in order to get a diagnosis. And why is that the case? Well, when you look at yourself through the lens of a patient with lung nodule, either detected through a low-dose lung cancer screening or through a CT scan due to other indications, so we'll call it incidental findings, they often bring this information to their general practitioner, who then subsequently refer the patient to a variety of subspecialties, professionals, interventional radiologists, oncologists, pulmonologists, or interventional pulmonologists. And then either through a transcutaneous biopsy approach or through a bronchoscopy approach, do you often get to the diagnosis. And this is why you're looking at 1.7 biopsy attempts in order to get a diagnosis for a single lung nodule. So let's take a step back and think about what is the scale of this problem about lung nodule in a national, on the national stage. So this past year, the detection for lung pulmonary nodules in high-risk population through screening, we were able to find about 420,000 incidents of lung nodule through screening efforts. And remember when I told you earlier, this is at 5.8%. The incidental nodule is much larger portion, it's about 1.5 million in terms of nodule detected. But what happens if we were to increase the screening from 5.8% to this lofty goal of 100%? Well, you can see that all of a sudden, the nodule detected through screening will overwhelm the system with nearly 7.2 million nodules detected through the entire year. So how do we prepare ourselves to handle the potential increase, this huge increase of lung nodules that come to our clinics? Well, at UCSD, we have a lung nodule workflow. This kind of recapitulate this very difficult approach, this very complex schema about how to guide our patients through this lung nodule pathway, evaluation pathway, and to facilitate communications with our referring provider. Now, when we really condense down that complex network of workflow that you saw earlier, really it comes down to three different pathways, three different distinct pathways. The goals are detection, that leads to a diagnosis, that leads to a therapy. And ideally, all of this are done in less than 4 weeks. What are our challenges that we're faced with? Well, we're faced with a few challenges. They're the scale of the problem that we talked about, a potential of 7 to 8 million nodules that come to our clinic on an annual basis, and speed at which we detect these nodules, and the speed to go from detection to treatment. And additionally, how do we better select for which of these nodules we should be aggressive in terms of asking for biopsy? And then all of this kind of focus on creating a common standard for everyone to follow when we encounter how to evaluate lung nodules. Well, most of our patients luckily have low to moderate risk for lung nodule detected. And what do we mean by that? Well, when you have a lung nodule, often we talk about the lung nodule through the size of the nodule that's seen on the CT scan. And the nodules often ranges from 8 to 30 millimeters. And we use a variety of different factors within the patient's clinical history to help us to stratify the patients into high risk, low to moderate risk, or very low risk. And you can see about 10% of our patients goes into the low risk, very low risk, 10% goes to the high risk, and vast majority of our patients falls in that 5 to 65% risk of that nodule being cancerous. So what is the next step when we encounter a patient with this with an intermediate risk? Well, low to moderate risk nodules are often managed very aggressively when you look at the current data. About 17% of these patients were sent to CT surveillance where they actually, the nodules that we are following are with serial CT scans turn out to be malignant. Perhaps even more concerning is about 62% of the biopsy that were done on benign nodules, and about a third of the surgeries that were done on benign nodules. Now, because of these challenges, we have adopted at UCSD a blood-based testing to help us further stratify our patients in that intermediate risk. By using this notified testing, we're able to stratify patients from that low to moderate risk to a very low risk or to a very high risk. And from that blood testing, we're able to then recommend a patient to perform a biopsy or to just monitor. So how do we illustrate this to you? Well, let's take this case. There's a 72-year-old female. This is actually a patient of mine who I met about 3 months ago. And she was a never smoker. She had a history of multiple breast nodules that were evaluated previously to be fibroadenomas. And these were actually followed by periodic MRIs by her outpatient providers. She was referred to me during one of the MRI. During one of the MRI, she was found to have an incidental nodule that's on the right upper lobe, and because of that, she was referred to me for evaluation. When we looked at her risk factors using those clinical factors of age, how the nodule appear, where the location is, the model that we use to calculate a probability of that nodule being cancerous is about 49%. So basically I told her, well, based on what we have with our current information, you fall in between that intermediate risk, the low to moderate risk category. So this is the CT scan for the patient, for this patient that we're talking about. And if you pay attention to this area, this is the right lung, and right at this region here, you can see that this is the nodule that we're interested in. And this nodule looks somewhat suspicious, and also I told her that this is about 50% chance of this could be cancerous. She was hesitant to move forward with a biopsy, and she asked us, what else can we do? Well, as I told you earlier, in our current pathway, we integrated the notified testing into our current evaluation pathway. And we basically drew 2 vials of blood from the patient, and we sent the test, Notify XL2 test, which returned by looking at specific proteins in the bloodstream to further modify this risk factor. So this 49% of risk malignancy, after looking at her blood level, have been reduced down to 6% risk of malignancy. And as you can see, that this huge reduction helped us to make a decision to say, let's pump the brakes and let's wait for a few months and see what the CT scan shows at a follow-up CT scan. So this is her follow-up CT scan. And as you can see that in this follow-up CT scan, this is the nodule that we're looked at from the prior film. And you can see that that nodule has shrunk in size. And because of that, we decided not to do any more biopsies and told her that, don't worry, this is likely an inflammatory nodule or a nodule that has mucus that's behind it. And we can just monitor this because tumor does not shrink, but inflammation and infection shrinks. So what happens if you actually if you found a nodule and we decided that that nodule needed to be biopsied? Well, this is where our robotic platform called ION system integrated with a real-time CT scanner that's in our bronchoscopy suite called SEALS comes in handy. And this is the system that we have at UCSD. So this is a robotic platform that allows us to get to the very, very periphery of the lung. We have a catheter that is very, very thin, and inside the catheter there's a removable camera. This camera can be taken out in order for us to put in tools that are flexible like needles so that we can sample the nodule in real time. And how do we do that? Well, we plan we take the CT scan and we generate a plan based on the CT scan and the map of the airway. And then we perform the procedure. And once we get to the location where we need to do the biopsy, we perform the biopsy. And as I mentioned earlier, we not only have the robot, but we also have a real-time imaging CT scanner in our bronchoscopy suite. So we can actually see in real time where the catheter is and where the nodule is when we're performing the biopsy. So how did that look in actuality? So this is a patient whom I met also in the past couple months. This is a 63-year-old gentleman with hyperlipidemia and hypertension. So has some cholesterol issues and has some blood pressure issues, and was found to have an incidental nodule about 9 millimeters in the left lower lobe. And this was done in April of 2022. And when we had a follow-up CT scan in December of 2022, it showed an increase in size from 9 millimeter to 11 millimeters. After discussion, he wanted to find out what this nodule could be before going forward with any type of treatment. So we took the CT scan, that this is his CT scan, and we were able to segment out the airway based on that CT scan. And you can see that here, all of the airways are actually highlighted. And this is the nodule that we're actually going to highlight ourselves. So if you see the next step, when we click on adding that nodule, we actually click on the nodule, and that nodule will then be highlighted in this turquoise color. And once that nodule is highlighted, we can also create a pathway to guide our tools, to guide our robot to this specific nodule. So how does it look like when we're navigating to this nodule or traveling down the airway to this nodule? So here's what the actual view will look like in the display, where you can see that we're traveling through the airway of this patient, going all the way to the nodule target in a very, very distal portion. And then once we perform the navigation, we will then use the CT scanner in the room to do a spin in order to generate a real-time CT scan, CT volume, that shows us the relationship between the nodule and the robotic catheter. And you can see this is actually not speed up. This is not sped up. This is happening at real time. This is how long it takes for us to do a single CT scan. So once the CT scan is done, we will have this image where the nodule is displayed here, and the catheter with a needle inside the nodule is shown here. And you can see that we're very, very close to the edge of the lung. But we know for a fact that the needle is inside the nodule, and that we know exactly the location where the needle is and where the catheter is. So we can tell in real time when we're biopsying the nodule that we're indeed inside the nodule, we're indeed taking biopsies. And we can do it in a safe manner, even though that nodule is very close to the edge of the lung. We know that in precise millimeters where our tools are. So this patient had a diagnosis of low-grade neuroendocrine tumor or carcinoid tumor, and this is a relatively benign tumor that could be easily treated with resection. So some take-home message from this conversation that we're having. Well, there are a lot of lung nodules out there. I think I mentioned earlier, up to 7 million by lung cancer screening, and then we're close to 1.5 million with incidental nodules that we're detecting. And as the population age, we think that there's going to be more lung nodules coming down the pipeline. So how do we handle this problem? Well, I think I presented to you all that all the calculation, the pretest calculation models that we have are quite limited. So the prediction model that we say, oh, this nodule based on the way that it looks on the CT scan, could it be cancer? Could it not be cancer? That's pretty limited. So we really need to use other tests like blood-based tests that looks at protein levels in the bloodstream to help us figure out and stratify further which patients should go on to get biopsies and which patients should not go on to get biopsies. And the biopsy procedure is changing the landscape for the future because all the new tools that are available to us, the robotic catheter, the robotic platform that is called ION, that wasn't here until 2019, right before the pandemic. And the integration of real-time imaging of CT scanners in the bronchoscopy suite, that's happening as we speak, also in just becoming more commonplace in the past 2 years. So it creates a very exciting future for us to improve our biopsy diagnosis and safeties and the safety profile of our biopsy procedures. So again, I'd like to thank you for your time. Again, my name is George Cheng. I'm the Director of Interventional Pulmonary Bronchoscopy and Pleural Disease at UCSD. Thank you again to the American Lung Association for this opportunity. So
thank you, Dr. Cheng. That was amazing. So, Dr. Cheng, we have a panel of members of the mission committee who are going to join us now. We'll have a nice little informal discussion in keeping with our theme of having a doctor for dinner. So we have Dr. Akathota, who's joining us, Dr. Montgrain, Dr. Al Hassan, and then Captain Lowry from the San Diego Firefighters. Firefighting department, fire department. I believe I've gotten everybody from the mission committee. So please, let me start off actually, and let me just make a comment that we often hear estimates about how many lives are saved per lung cancer screening scan, and that's depending on pretty old data about how accurate diagnostic tests are and what the complications are of the diagnostic tests. So we'll commonly see things that say like, well, we do a lung scan, we do 100 lung scans, we find 3 new lung cancers, but we, get 1 extra pneumothorax or something like that. And I obviously just made those numbers up. But should we change our opinion about that based on the type of things that you talked about? Are things more accurate and less risky for complications now?
Well, I think what we can be confident about is that we have 2 things. One, we are not doing enough in terms of lung cancer screening. And number 2 is that if there is a lung nodule that is detected on the lung cancer screening, we know that now the biopsy approach to that lung nodule is actually at a much safer profile. So I think that in terms of where we can actually do better is really to encourage people to not worry about engaging in participating in lung cancer screening. They should participate in lung cancer screening because it helps us to really drive that well-proven benefit of lung cancer screening, which is a reduction of cancer mortality of nearly 20%. So that's important to keep in mind. And also that the number needed to screen in order to save a life is often quoted as 320 screen to save 1 life. And if you broadcast that in a population like San Diego population, which we're close to around 3.5 million people, we can save a lot of lives if we just do well in our own backyard. And I think it's very important to drive that message home. Make sure that if you're eligible for screening, please participate in screening. Do not be concerning yourself about the safety of the biopsy or the evaluation afterwards, because we are doing everything we can to make it as safe as possible.
I would just like to make a comment, Dr. Morris, if that's okay.
Please.
I think your point is very well taken, that the numbers we quote, like the number needed to screen and how many cancers you might find and how many complications of procedures. Those all come from a study that was published in 2012. And correct me if I'm wrong, Dr. Cheng, I believe most of what you showed us today, which is fascinating, is pretty new and probably was not being used when this national lung screening trial was done in the years preceding 2012. So I do think the data we're quoting is old. And I think we can probably do a lot better than that data with the new technologies we have to reduce risk, get an accurate diagnosis more quickly, more safely. And I wouldn't be surprised if our lung cancer screening results would be even better than those published in that old study.
Absolutely, Dr. Mongrain, completely agree with your assessment.
So, Dr. Cheng, could you explain for a moment what you mean by complications of these procedures? Because Dr. Mongrain just mentioned that you have a certain number of complications if you try to do a biopsy, and that maybe the new techniques might reduce those. But what's a complication of lung biopsy, and why do all these fancy robots and everything, why do they make them less likely to happen?
Thank you, Dr. Morris. So that's a great question. And I think whenever we perform a procedure, we always think about what is the risk, what's the counterbalance. So there's benefit to each procedure, but what's the risk to the procedure? Well, the risk for any procedure that we perform often falls into three large buckets. So either an infection that's associated with the procedure, or bleeding that's associated with the procedure, or in the case of lung biopsy, is the pneumothorax or collapsed lung that can occur with a procedure. So if you look in a traditional model where we detect a lung nodule, and 10, 15 years ago, when we didn't have these type of technologies, often the patients are sent to our interventional radiologist colleagues to get a transthoracic or transcutaneous biopsy. So that's where we take a needle, go through the skin, through the muscle, into the lung in order to get to that nodule to take a biopsy. In those situations, about 20% of the patient experience what's called a pneumothorax. And what that is the collapsed lung that we talked about. And why is that the case? Well, because we actually have to violate the covering of the lung in order to get a piece of the tissue of the nodule to get a diagnosis. Now, what about bronchoscopy approach? Well, bronchoscopy, the robot approach that we're talking about here, go through the mouth, into the airway, down to the periphery of the airway, right up against the nodule and take a biopsy without violating the covering of the lung. And the general sense from all published study is that the collapsed lung risk is about 10-fold less. So, I think you're looking at about generally 2 to 4% chance of causing a collapsed lung or pneumothorax. Bleeding risk and infection risk are also often less than 1 to 2%. So these are the complications that we worry about when we perform a procedure like this. And I'm very glad to say that with this new integrated approach with imaging and with a very precise robotic controlled catheter that gets us to the periphery of the lung and perform the biopsy, we're able to reduce that risk profile even farther down to about 1 to 2%. So it's a great change. And again, highlighting the fact that this change in practice only occurred and was only made feasible in the past 2 to 3 years. So any other
George,
questions?
Yeah, no, George, I was just going to say, the way I'm a simple guy, as you know, the way I like to think about it is it's almost like being in the age, we used to be in the age where we had to get somewhere. We had our road atlas in the passenger seat. We had the atlas open. We were driving, looking at the atlas, driving, and that's how we got somewhere. But now with the robotic techniques, other techniques, it's like having your in-dash GPS kind of giving you turn-by-turn directions, and then you're there. It's a lot, there's a lot more technology to get you from point A to point B without a lot of distraction, without a lot of not knowing whether you're getting there or not accurately. And kind of your intuition tells you that gets you a better sample, and it gets you a better sample in a safer way.
You're absolutely right, Dr. Escobar. That's actually the way that I actually make an analogy in some of my talks is that back then when we were doing the bronchoscopy, we didn't have this new technology. It's like driving an old beat up tractor trailer, and now we're driving a Tesla. So so that's
I
the
didn't
difference.
realize you guys were so old. So I'm just happy to hear that you're still active and everything. So maybe could you talk a little bit about the other side of it that, and maybe Dr. Monkering, feel free to jump in on this one too. That if we diagnose things safer and more effectively, maybe even earlier with advances in scanning and biopsy techniques, does that make a difference to therapy? Is there an opportunity there? Are the opportunities better now than they were 10 years ago regarding recovery if you can find something early?
Yeah, absolutely. And I'll pose a question to Dr. Cheng also at the end of my comment. But yes, we know that lung cancer is much easier to cure when you find it earlier, and that can be as simple as finding it when it's localized, hasn't spread to the lymph nodes, hasn't spread anywhere. Cure rates are much higher. But we also know that just finding lung cancers when they're much smaller, you may be able to treat them if they're early stage and very small without removing as much lung. So classically, the treatment for lung cancer has been what's called a lobectomy, which is to remove the entire lobe of the lung that the cancer's in. But that may change as we find cancers that are much earlier, less aggressive, and smaller. We may get away with other treatments, removing less lung, maybe perhaps just an anatomic segment of lung. But my question to Dr. Cheng is, and I'm going to ask you to speculate a little bit here and look into the future, but do you see a time when you will be able to diagnose and treat in one procedure? In other words, very, very small early lung cancer, you're getting in it anyway for your biopsy. Maybe you can kill the tumor right then and there. And do you foresee that happening in the future? Because certainly I think that would be of interest to our public.
Yeah, and Dr. Montgomery, thank you for that question. I think it's a extremely exciting age that we're living. Things are fast. Things are changing very, very fast. Even as we speak today, not in the future, today, there are active clinical trials are ongoing in both in Hong Kong and in London, using exactly what you described. Catheter-based approach, going to the periphery, getting a biopsy, getting a diagnosis, and then potentially deliver some type of energy there to treat the diagnosed tumor. Now, that being said, this is a very early stage evaluation, and I would say that where exactly is this gonna fit in the current treatment paradigm is still unclear. How effective it is still unclear. But what is clear is that we are at a point where there's a lot of work being done here in this area we described, and we're actually here right now. We're partnering up with our thoracic surgery colleagues at UCSD with Dr. Onaitis and Dr. Joshua Boyce, Dr. Patty Thistlethwaite, to explore options where we can combine both the robotic platform from ION, the catheter-based approach, and the robotic platform from Da Vinci and the robotic surgical approach in one single procedure, where we can then go in, do the diagnosis exactly like you said, get a diagnosis, certain for sure, once and for all, that nodule is cancer and that no lymph nodes are involved, no distant disease, and then at the same anesthesia event, our thoracic surgeon can go in and remove that disease area using our current proven clinical process, clinical paradigm. I think that's what's exciting right now, what we can deliver to our patient population, where they can come into us with a non-nodule, and if it turned out to be cancer, we could potentially treat it all at one time.
That can happen today. The other catheter-based approaches are probably a decade, 5 to 10 years away.
George, who should get screened? There's all these tools for people who have lung nodules detected, but if it's all about having people get the screening in the first place, who are the right people to go in to get a screening CT scan?
Yeah, so I think this is where you have a lot of opportunities to improve, right? So lung cancer screening criteria is focusing on really the risk factors of lung cancer. What are those risk factors? Well, you have smoking as a risk factor. So if you have smoked for about 20 years or more, that is a considered risk factor that you should think about. Oh, maybe I should go and get myself evaluated with a low dose CT scan. Age is a risk factor. So 50 to 80 years old in that age group, then that's something that you need to think about. Get yourself to evaluate it, and also any current or former smokers. So what's current? Well, current smokers, you're still smoking now, or you have quit within the past 15 years. Those are the times, or those are the individuals that if you fall into those categories, quit within the past 15 years, smoked 1 pack per day for 20 years, so that's when we talk about 20 pack years, and between the age 50 to 80. Those are the patient population that would be beneficial to undergo lung cancer screening. That being said, there are currently a lot of interest in looking at the incidental nodule population, the group that basically had a CT scan that was done for a different indication, for a different reason, but found to have a lung nodule. In that population, we noted that there is actually a good portion of that patient population are also these nodules harbor tumor cells. And they often fall outside of the screening group recommendation. So we're currently trying to tease out how we can capture that population, more effectively.
Let me just add, by the way, that in case you couldn't remember all the things that Dr. Cheng said about risk factors, there is a quiz for that, or questionnaire on the Lung Association website. So if you just dial lung.org, you go right to the face page, and there should be there's a button right there that says evaluate your risk for lung cancer, and it can tell you whether, at least according to the the information that Dr. Cheng was talking about, whether it would be advisable to get a screening scan or not.
I had another question, Dr. Cheng, if that's okay.
Of course.
You mentioned for these indeterminate nodules, these gray zone nodules, which is 80% of them. It's most of them, and anyone who's a pulmonologist knows because it's a lot of what we deal with. When they're high risk or low risk, it's easy, but when they're in that gray zone, we're looking for more information. And you mentioned one of these, these classifiers or modifiers that you can use to kind of determine whether, do we want to be more aggressive with this one, or should we pump the brakes, as you said nicely, and watch this one? And you mentioned doing a blood test that can be helpful. Are you aware of any other modifiers or classifiers that are coming along? Perhaps looking at exhaled breath, or a little scraping of your nose, or anything, or anything else beyond what you guys are doing that is coming in the future that might be really helpful?
Yeah, I think Dr. Montgomery, thank you again for that question. I think that there are actually a lot of companies that are actively working on this particular problem. Some of them are blood-based tests, like you said, like the test I mentioned earlier, Notify XL2. Others are looking at currently clinical studies still, but they're looking at validation component right now, a scraping of brushing of the nasal passage, taking to this idea of a field effect theory, where if you're smoked, the genetic changes that's in the nasal passage should mimic the similar changes in the lung, and potentially looking at a variety of genetic changes in that setting to have a prediction. And what's more exciting is I think there are actually non-invasive approaches that look at the existing CT scans for patients, looking at features of on the CT scans that could potentially predict the arrival or arisen of tumors by looking at a collection of features. And this is a CIBL program at Mass General that they're looking at this particular AI-driven approach. And as we live and embark in this age where we're physically currently living through this artificial intelligence revolution, everywhere you turn and look, you hear AI. And I do think that in medicine, we will be one of the first fields to take advantage of this, where a lot of the work will bear fruit in the next 5 to 10 years, where you'll help us to better diagnose, better predict, better prognosticate the patients with lung nodules who may turn out to be cancer. So a lot of these, I know these are general, but a lot of these working a lot of these studies and this efforts in the works, they're very exciting, very, very exciting.
You know, it seems to me almost like an analogy would be if you were trying to pick a card from a deck and you were playing blackjack or something like that. A lot of these models are saying like, well, it can't be precise. You can't say absolutely what something's going to be. But if you removed all the, the hearts out of a deck and you eliminated something like that, or you took all the clubs out of the deck, eventually you're going to get down to a pretty good chance that you're going to be right about your estimate. And then that may weigh your decision about whether to follow it or whether to do, a biopsy right away. And I don't suppose any of this stuff says, okay, take your eyes off of it, and don't pay any more attention to it. But it can say whether it would make more sense to do something invasive or not. Is that correct?
Absolutely. Yeah. No, I think so. And really, it helps us again to have a more in-depth conversation with our patient who's sitting in front of us, who has this lung nodule, who's worried, rightly so, and have that conversation with that patient and the family, and explain to them, this is not just coming from me having 50 years of experience in the field looking at CT scans, but rather quantify that clinical gestalt, distill it to numbers, facts that our patients may have a more intelligent conversation with our patient. Our patient will appreciate.
This is a comment. Go ahead, Dr.
Oh, I was going to say, and sometimes you just need a little bit more time if it's still a gray zone. If you just look at something once quickly, you don't always get a sense of what it is. Sometimes you have to look at it longer. Then that means sometimes a second CAT scan in a couple of months or more, and depending on what you're seeing. So that's also a part of your toolbox when you're trying to figure out what to do with somebody. Correct, George? I know I'm putting words in your mouth, but
no, it's true. It's true.
Yeah.
Something I learned tonight was the advantage of having a lung nodule evaluated by not just a good, smart doctor sitting alone, but by a whole system. That there's, when you consider the number of lung nodules that are out there and the various different pathways that you can turn, that can go all the way from saying, yeah, let's do a lobectomy to take this nodule out, and before we can see what it is, or do a wedge, surgical resection, versus just saying this is fine and let's just keep an eye on it and we'll get a scan next year. And I think that and then a range of all the things in between. And I thought it's a real advantage to choosing to have a lung nodule looked by somebody who spends virtually their whole life looking at lung nodule and deciding what to do about it.
Yeah, and I think that's where from my experience, I noticed that at the VA we have this lung cancer tumor board, and really it's also a lung nodule board, tumor board, that evaluate lung nodules that arises. I don't know if Dr. Montgomery can kind of comment a little bit about the process. In terms, it seems it's a very thorough process.
Yeah, I think it's really important, like Dr. Morris said, not to just have one set of eyes looking at these things. And I think having a multidisciplinary or interdisciplinary conference is really the way to go. And I don't think we're unique at the VA in having that, but we are blessed to have that here. And essentially you have all your experts in one room together. That's your lung doctors, your cancer doctors, your radiology doctors, your X-ray therapy doctors, your surgeons, your pathologists who look at biopsies under the microscope, everyone together in one room, and you go every kind of new suspicious nodule or new diagnosis and spend some time on each case, getting a multidisciplinary opinion and then recommendation for our patients. And I think that's really the way to provide the best care, is to have a room full of experts, not just one person.
Yeah. More brains is better than one.
Always.
Right. Let me see. I have one other question or comment in the chat book. George, hold on just a second. So, and by the way, I'm reminded of Dr. Akathoda. He's an asthma expert, and there's a fair amount of information out there that complicated asthma patients are probably best seen by somebody who spends a lot of their time seeing complicated asthma patients. And there's a certain point at which, even a general pulmonologist should take a step back and let a sub-specialist take a look. All right. Unfortunately, we're reaching the end of our time. It's too bad because I could do this all night with you guys. This is really a fascinating topic. But let me stop here by thanking Michelle from the Lung Association for setting all this up, and Rita for your leadership. Thank you to our panelists, Dr. Alcathota, Dr. Montgrain, Dr. Al Hassan, and a special thank you to Dr. Cheng for a brilliant talk about lung cancer diagnosis. Everybody take care of yourself and enjoy the month of May, and we'll see you at the Turquoise takeover around town. Wear your turquoise. Bye-bye.
Terrific. Thank you all. Good night.
Bye-bye.